Hi, good afternoon, and thank you all for coming here. And I'm going to briefly discuss the issue of neurostimulation. And I'm not going to go over all the slides. I wanted to show them, and the main message that I have for people with epilepsy and their families is that there's a lot to do and there's a lot of hope and a lot of things that we need to do and and I think that what we need to address is that there are a lot of people with epilepsy, and this is a wonderful opportunity to increase the awareness of epilepsy. And it does affect millions of people in the United States, and you're talking about 70 million people in the world. So it is a global condition. And one thing that we as practitioners and healthcare providers and physicians and advanced practice nurses have really tried to talk more about is also the risk of SUDEP in a lot of patients, sudden unexplained death in patients with epilepsy. And that's especially a problem in patients that suffer from drug resistant epilepsy. And since there are more medications, and we're very grateful for the fact that there are more medications, but we do know that about 30% of patients with epilepsy suffer from drug resistant epilepsy where they don't respond to medications. And I just wanted to go over again, just briefly, what we uh, call and what we talk about as being drug resistant epilepsy. So, drug resistant epilepsy is defined of us not being able to respond to medications, and it could be one medication and then followed by another medication in separate trials, or even if we're adding another medication to an existing medication, adjunct therapy. So one of the criteria that was like really pushed is that every person with epilepsy that has failed medications or meets criteria for drug resistant epilepsy should be referred to a comprehensive epilepsy center to tailor things. And that includes like having a pre-surgical evaluation. But sometimes patients have not responded to medications, and they are not candidates for epilepsy surgery, and that's where things like neurostimulation um, um, came about. And it's important also to note that we've had a lot of therapies, advancements in therapy over the years. And one thing that we'll talk about is the vagal nerve stimulator. And I'm going to also discuss briefly when is vagal nerve stimulator supposed to be the best treatment for it, and when do we have alternate. And I'm going to bring some examples of it. So one is neurostimulation is an option. And right now, although it's a little bit different for the pediatric population, vagal nerve stimulation is available for the pediatric population. I am also going to talk about responsive neurostimulation. And even though it's approved in adults over the age of 18, there are ongoing trials to get it into a pediatric and adolescent indication. And the same with deep brain stimulation, which is also an option. And I can later answer also questions: when do we do when do we do VNS? When is that more appropriate? And when is responsive neurostimulation more appropriate? And when is deep brain stimulation more appropriate? So I'm going to go over briefly over these things. And one of the things
It's a
that
little different this year still. Right.
hi, I just want to make sure that people can hear me. Basically, there are many targets for neurostimulation that we talked about. But what we're talking about right now is three FDA approved modalities. One is the vagus nerve. The other that's approved is a responsive neurostimulation, where we can put electrodes into up to two different foci. And the other is the deep brain stimulation. The FDA approved target is the anterior nucleus of the thalamus. And that's basically where we're looking at. And this shows you that what we're dealing with is a variety of neurostimulation approaches. What I do want to stress is when we're talking about neurostimulation, we're talking about a palliative procedure. So it's important also to set expectations in resective epilepsy surgery in patients that have um, temporal lobe epilepsy. The seizure-free rates are quite high, 70 to 80%, if everything, all the data is aligned. But when we're talking about neurostimulation, we are talking mainly about palliative therapies. But even those palliative therapies, what we have is a 75% reduction, median reduction in the frequency of the seizures. We also have a dramatic decrease in one of the most dreaded issues in epilepsy, which is the sudden unexpected death in epilepsy. And we see that reduction in all the three approved modalities. So I do want to discuss RNS, and which is another thing, another relatively new modality. It's not so new anymore, 2013, but still, I think the last 2 years we've been involved with the pandemic, so it's really not that long ago. So what we're talking about responsive neurostimulation, and that's currently approved for adults, um, is that what we're doing is we are trying to have what's called a closed loop device, which means that we've identified where the seizures are starting. We can put up to two electrodes, two four contact electrodes in two different areas. And that solves and gives an array of hope to patients, let's say, that have seizures coming from the right and the left temporal lobe. So they have like bitemporal seizures. And those patients previously, when we did an evaluation, we put depth electrodes or we did a video telemetry, and we found out that their seizures are coming from both sides. We didn't have a lot of options to offer these patients. So now we can actually put one lead on the right temporal lobe and another lead in the left temporal lobe. Another example that is we found out that her seizures are coming from the language areas. And because her seizures are coming from the language areas, we obviously can't take out that region. So we actually put that area and stimulate that area. And because we stimulated that area, we were able to abort the seizures. So what's unique about the RNS system is that we actually, and I like calling it a pacemaker for the brain. And what we do with this particular pacemaker, the brain, is that we we implant a device, and we're able to look at the waveforms of that device and look at that particular patient, exactly what the pattern of seizures are in this particular patient. And when we look at a pattern of the seizures, we're able to really individualized, some people call it precision medicine, but what we're doing is we're looking at a specific pattern, and then that pattern is detected by that device. And once we detect that pattern, that pattern can be um, used to when to trigger the trigger the device. So that's something that I think is very important. So we individualize, we monitor the brain activity, we detect the specific patterns, and it stimulates automatically. And we can actually program the device. And each patient or their caregiver is given a laptop where they can, what they can do is they can specifically um, upload the information, and we can review the information and see what happens. I think it's also important that we now have the ability to monitor patients for months and years. So I learn more about the patients over time, and we can see if a certain patients have um, more seizures during the day or the night, and other patients have seizures that occur in other times. So I think one of the things that I would like to do with it, and a lot of people are doing with it, is using it for what we call seizure forecasting. And I'm just showing you like how it looks and how we can program things and look into things, so you can see those waveforms, and it just shows you that it picks up what looks like a seizure, it picks it up, and it stimulates it, and the patients get a tablet. One thing for a lot of you that have a VNS, we use like a swipe that the patients can swipe, but the swipe really only tells the patient, it and us basically, hey, this is when I had what I think is a seizure. It doesn't stimulate. I know with the vagal nerve stimulator, sometimes you can actually look at that. But I think one of the things that I like is it empowers patients, and the patients can be partners in their treatment, and we learn from the patients. Um, okay, we have more seizures, less seizures, and I think that that's something that is important, because patients can realize what times of day that they have seizures, whether it's more day or night, and or in women, um, and actually not just women. We found a lot of men and women that tend to have seizures that occur every 4 weeks. Just an example. Um, Basically, just to show you that there was like reasonable data to support it, and it's been FDA approved. But this is basically what we do in our thought process is what to do. So obviously, seizure freedom is more with resective epilepsy surgery. So it really depends. We only do that if there are two places, and that is also something that when people think about when do we use what VNS, when do we use DBS, when do we use RNS. So if we find that the seizures, like patients with Lennox-Gastaut or patients that have seizures coming from multiple areas of the brain, we don't know where to put because we can only put the RNS into two places. So those patients would be better candidate for deep brain stimulation or vagus nerve stimulation. So those are things that we take into consideration. And this basically shows you like if we localize all the seizures, we can resect. There's no cognitive risk and we want seizure freedom. I would still say yes, go for resective epilepsy surgery because that's a more definitive procedure and not neurostimulation. But if you have two areas, you can't resect two areas usually, then RNS or neurostimulation is a better choice. Or if you have one area and that area is unsafe uh, to to that. These are older slides, but just to show you that those patients, even those original trials, were already followed for a decade. And one thing that is very typical for patients with all the neurostimulation modalities is that it takes about a year to 3 years to really get into the peak efficacy, which I think is very important because I always tell patients they're like, we started programming the vagus nerve stimulator. We started programming the RNS stimulator or the DBS stimulator, and they want to see immediate results. Well, some do, some are lucky to do, but I have patients that it took me 3 years to get into good results. There is some advantages because a lot of patients that are getting medications, those patients that are getting medications, what's very common with medications, what's called a honeymoon effect. Not with every medication. Some patients have sustained seizure freedom with medication, but I think that's important to note that things get better over time, and that's something that we're partners with all of you, and I think that that's something that's very important. So just to show you that RNS, when they looked, it works not just in temporal lobe seizures, but also seizures that come from the frontal lobe. And we have patients coming from the occipital lobe. And you can see basically that the results get better over time. And, and, and another thing is that patients have periods of seizure freedom. So if people ask me what percent of patients are seizure free, so it's 15 to 20% or 15%, really depends on what series, and also depends what you define seizure freedom. Because one common thing that we're dealing now is actually asking patients, how many 6-month period of seizure freedom do you have? And I, of course, we all want seizure freedom, but 6 months when there are no seizures, that allows children, adolescents, and adults to pursue other things is important. They don't get behind. These are things that are very important. So we can look and see that what we found also in real life is that the results we are learning, we're still learning, I'm still learning more and more. And the FDA has done what's called post-approval trials. And actually, if we look at the post-approval results, they're actually even better than the trials that were used to do. We get results faster, and I think part of it is because we have learned more as far as how to program the device. So those things are very important. If we look at the UCLA, and if we look at both programs, this is an older slide. I think at UCLA we have already like about approximately 100 combined between the adult and the pediatric population. Um, we have about 100 patients, so we're gaining more and more experience. We're also the pediatric program is embarking on doing trials on adolescents and with RNS, and I'm extremely hopeful. Um, and another misconception that I want to clear is that if you look even at the trials that were done, um, we have patients are if you have one device and you failed one device, it doesn't necessarily mean that you will fail another device. If you look at the patients with if you look at the patients with um, that have had, if we look at our patients that have had um, RNS or DBS, a large number of those patients did not have did have other devices. So if somebody did not respond to a vagal nerve stimulator, it doesn't mean that they're not going to respond to another stimulator. And the other thing that I want to point out is that we have in the clinical trials we had to only use one stimulator, um, but in clinical practice we could use um, multiple stimulators. So I have patients in clinic that I program both the DBS and the RNS. So one does not preclude the others. So that's another thing that I wanted to reiterate. These are just examples of different cases. I'm not going to go too much. Everybody now is talking about big data. And as far as the patient perspective, we're still learning. The fact that we can upload computer all the various and see. So I think that that's um, so I think that that's something that is very important to note. And this is just going over showing things. And one thing about each modality, and I'm a big proponent for each and every modality, whether it's RNS, DBS, VNS, what we can see from the outcome data is that we see good results. We do know that with RNS, the patients usually, I mean, I say that usually because it's not always the case. It's usually you don't see anything, you don't feel anything. So patients don't feel anything during the time the stimulation. And I know with VNS, which I'm going to also discuss, some people feel like the voice and the hoarseness in the voice. A typical VNS, and I know the patterns change between time. So every time there's a different way, different patterns. So let's say you are doing 1 minute on, 5 minutes off. That's a certain pattern that appears. Um, so in with RNS, you're only having stimulation um, approximately a few minutes a day. So even if there are like lots of detections, you actually can have it only a few minutes a day. So that's something that I think is important also to note. You can see as far as results that the results are there um, for many cases, both in occipital and parietal, frontal. So it really helps in seizures in different areas of the brain. And you can look and see that they're about 15% is showing like from some manuscripts or data that's been published. and you can see that about 1 out of 6 patients actually achieved seizure freedom, which is quite impressive. Um, Again, I think what's very important is quality of life, and we did a lot of studies on seeing whether there's any effect on anything. What we found is over time, there's no adverse effect, but some people, and it's been published, have um, improvement in quality of life parameters. And I think that's very, because what we're talking about in epilepsy in general is we're talking about improvements in quality of life. So you can look and see that there are improvements in quality of life compared to baseline. And I think overall, um, this is something important. Um, this slide, and that's the same I think I mentioned in the beginning, because I really want to convey key points to the audience, is sudden unexplained death, which is something that I unfortunately, I've dealt with. The last time I've dealt with it was last week when the patient was supposed to come to clinic, and I have not had that patient come, and it's always devastating. And I have vivid memories, and I treasure, and memories of patients that and their families that were afflicted with SUDEP, and I respect each and every one of them. So for me, having neurostimulation really decrease the number of sudden unexplained death rates, and especially in patients, we're talking about patients with um, drug-resistant epilepsy that are at risk for having epilepsy, for having death from epilepsy. That is something crucial, and I can't, but I can't even overestimate it. So seeing such a drastic reduction in the risk of sudden unexplained death, to me, is something which is amazing. And in general, I think that one of the things that I wanted to point out to all of you is that seizure frequency, yes, it's important, but one thing we see across the board with neurostimulation is the seizures becoming briefer, and people recovering a lot faster. So those are things that I wanted to keep in mind. This basically shows that we can even look at the seizure patterns over time and decide whether things uh, um, are at a particular point of time. I'm just going to go over that. I wanted to another modality, which is called deep brain stimulation. It's been around for movement disorders, and what we do is we implant patients. We implant patients with we implant patients with over the anterior nucleus of the thalamus. And this is currently just approved for adults. But this procedure may be good for patients who have more than two foci. The thing that's approved right now is putting it over the anterior nucleus of the thalamus. The anterior nucleus of the thalamus, which is a particular place. It is connected, especially with areas of the temporal lobe or frontal lobe, um, that what we call our limbic.
So sometimes we have seizures that we know coming, let's say coming from the temporal lobe, but those particular seizures may not have a distinct onset. And I'm going to show you briefly an example of a patient that demonstrated that. And you can see that even when you implant patients with a deep brain stimulation stimulator um, over that area, um, um, stimulated over that area, even if you say you look at that, then you can see that you have a reduction of seizures also over time, which is also about 70%, 75% reduction seizures over time. And this is just another way of showing it. And I'm going to give some patient examples. It's well tolerated. In initial studies, they had depression, but that's something that we really didn't see a lot. And this is like actually showing you how these are targeted and the patients really don't feel anything. And our experience has been that when we implant it, that if we start stimulation really slow, we don't have depression or neuropsychological feeling side effects. Um, so that's something that I think is important to note. So I think that that's um, 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 something that I think is important to note. I'm just going to show you how the device looks. Uh, but there's currently another device that we can see that actually gives us some information. It's it's information from the recordings that are called local field potentials, which are potentials that are seen over that area, which could be also important. I'm going to skip some of those slides, but um, what I can give you is some patient examples. So I'm going to give you an example of this particular patient that we um, recently put in a deep brain stimulator, and this particular patient, um, this particular patient is 20 years old, and she started having seizures at the age of 12, um, and uh, and her seizures were poorly localized. I think that what we found is that her seizures, she moved her head towards the right and she had generalized seizures. And we do know that patients that have generalized seizures have a high risk for SUDEP, for sudden unexplained death. She did try multiple anti seizure drugs. And she has on the EEG, we didn't quite see any great great localization. So I think that that's something um, that is hard sometimes because we don't know which patients to put electrodes to find out where their seizures are. And sometimes, especially since she had the imaging studies like the MRI and the PET scan really didn't show anything, uh, we decided in this particular case, this with this particular patient, to put a deep brain stimulation. You can ask, why didn't we consider RNS in this particular patient? We couldn't. We knew it was possibly coming from the left side, but we didn't have two places where we could see where to put the um, electrodes on. So I think that that's something that's important for us to know, that I always want to use the right treatment for the right patient, and sometimes it may be medications, ketogenic diet, and at other times this treatment may be surgery, and at other times maybe neurostimulation. So I just wanted to show you some, and this is like fresh out of the press, because what we actually found out in with this patient is that we actually captured a seizure. And since we now, with the device that's been approved just about a month ago, we can actually look and capture events and see what happens. So this patient had a seizure in clinic that we were able to record. But what's interesting about this patient is we saw that it actually showed us that there was activity over the left thalamus and not over the right thalamus, which was very what we suspected, that her seizures are coming from the left side. And we also set up to look. So we basically now have, even with deep brain stimulation, we also have the ability to some degree of making what we call the closed loop, which means we can actually monitor. It's not exactly closed loop right now because we program in particular times, like in this particular patient, 1 minute 1 minute on, 5 minutes off. We can do even things continuously. But I think that that's something important to note, that now we can, even with deep brain stimulation, monitor and look at different patterns. And we find out that she has more seizures at night, or she has seizures at particular days or times. And what we found is that right before she had a big seizure, there was an increase in activity. So I think in the future, when we deal more with more advanced seizure forecasting, maybe we'll be able to give back to patients with seizures more control over their lives, knowing which periods are more vulnerable and which periods are less vulnerable. So I think that that's something that we're all looking forward to, which I think is going to be important um, to all of us. So I think that that's something.
Dr. Elisha, I don't
Yes.
think we are seeing your slides.
Oh, you're not seeing the slides.
No, can you share the screen again?
Yeah, definitely. Thanks, Sam. Is it Sammy?
Yes.
Okay, I recognize your voice. Let me see what's happening here.
If you just reshare your screen, I think it will appear again. Yes, we can see it now.
Okay. Did you see any of the earlier slides, or you didn't see?
It disappeared for the last 5 minutes or so.
Okay. Um, yeah. Then let me just show, since just I showed a patient that was 20 with DBS, and basically what I showed earlier is that what we can do now with deep brain stimulation is actually look and isolate a pattern that is specific for the patient, and monitor it over time, which is something very new, hot to press with deep brain stimulation. Um, so I'll go now to vagus nerve stimulation. That's been approved since 1997, which and I still, it's a great treatment, and a lot of patients, you know, I discussed earlier, you have two specific foci or areas where you think the seizures are starting. RNS may be a great tool. DBS may be great if you localize things to like both temporal lobes, but it has a very widespread distribution. But for a lot of patients with, especially patients with, not just, it will work with lots of seizures and lots of types of seizures. But but if you're looking at a population that's um, um, looking at a population that's has if you're looking at a population that has Lennox-Gastaut, multifocal seizures, drop attacks, and so those are things those things are important. So when we look at vagus nerve stimulation, has been approved, and the indication is lower in age, so it is approved in a lower in pediatric age. The slide is slightly older. So the side effects, as you know, you have hoarseness, but a lot of times what I want to stress with vagal nerve stimulator is that the hoarseness gets better over time. A lot of patients have coughing during the initial time, and then afterwards, afterwards you have disappearance of these side effects. So what I urge a lot of patients is have patience, no pun intended, and the results get better with time. What I really love about the VNS right now is that right now we have with vagal nerve stimulation, we can do auto ramping, which really I know, especially with the pandemic, when people are more aware of having seizures occurring during different and having less access coming to clinic, especially during the pandemic. I think the option of having the auto ramp feature with the vagus nerve stimulator, I think that that's something very important, and it allows to have less visits, and it could do an auto ramping. And the new devices also can have smaller increments. It used to be that I could only program devices and program them only 0.25 milliamps. I think the ability now that you can do it also 0.125, I think that's something which is great. Another thing that the last few years they have, and it's not good for every patient, and we don't necessarily, and for those of you who have VNS or have a child with VNS, you don't always have to have the AutoStim feature enabled, but if you have, there is, we do know that with certain seizures, we have increase um, we have increase in heart rate, and the increase in heart rate is what we're looking for, and it looks for automatically looking for sustained increase in heart rate, not not unsustained. And because it's sustained, it's not just if somebody starts running and jumping and their heart rate goes up and it triggers the machine. It looks for sustained. So what we found out using the VNS is that some patients can benefit from what's called autostim. When there is, some patients have a heart rate increase, and this just shows you a picture, and it's hard really to say here if you're not reading squiggly lines every day like we do day in and day out. But you can see here you have seizure activity, you have stimulation, and the seizure activity stops. You know, the line becomes more flat, and a lot of times when we do that, what we find is if we stop the seizure faster, um, the prognosis is better. We're able to get a better result. So there is some data to suggest it, and that's, I think, is something very important that really helps for some patients. Um, so I had to show these slides to our neurosurgeons who said, why use a newer device rather than an older device? I do want to say that usually you can change the device quite easily, but for those of you who have a dual pin device, then you have to do a whole revision and of the device, and it becomes more complicated. So it's not always crucial. And if you look at the data to support VNS, you can see, and I really like quality of life. I'm a big fan of quality of life in patients. And then you can look at the quality of life improvement over time. And you can see that there is quality of life compared to alertness is something that I've seen. Whether that alertness is because patients are having less medications or less seizures, that's something that you can argue about it. But I've really universally seen with patients with vagal nerve stimulation is that they wake up much faster. And they don't have seizure clusters. I mean, and now there's like intranasal formulations. I'm sure that you will hear about it, or if you haven't heard about it. But that's something that I think is very important. And I've seen that with a lot of patients with vagus nerve stimulation. We doctors like acronyms, which, BMP's best medical practice. But this basically shows you that after a year, we have significant improvement in the quality of life in patients that have vagal nerve stimulation. It's not instead of medications, in addition to medication, but you can see even a year out that there is really a significant improvement in quality of life. And you can also look and see, I think I discussed that beforehand, is that a lot of the side effects are transients and diminish over time. The thing people talk most about is hoarseness, and you can see that, um, a third will have hoarseness in the beginning, but then when 3 years later, they don't even pay attention and don't even notice a lot. I'm not saying everybody, that when the VNS is on, off. And this is one of my biggest crusades for promoting neurostimulation, is that there is a significant reduction in uh, the risk of SUDEP, sudden unexplained death. And you can look and see that's a 30% reduction. And if you follow people, look even more, and that's really statistically significant. And you can see that the rates get, they're like, it's sustained, and it gets better over time. Um, for those of you who want to take snapshots of the VNS thing, but this is like something that I've really loved during SUDEP, is that I could have guided. I mean, I can have you can have you and your physician decide on a different protocol. You don't need necessarily to go after it. But what I found is that instead of dragging patients to the office again with COVID and everything, the ability to have guided programming where there is an automated auto ramp, I think is important. I'm just going to show you briefly before we wrap up some brief examples. And this is an example of a patient, and she's a little bit older now, but she was 26. And her seizures basically were characterized by having gibberish. So, in the beginning, even we thought that her seizures may be coming from the speech area. And we did the studies, and we didn't find any tumor or any lesion, any focal cortical dysplasia, either in the MRI or the PET. We found, and she's right, she's like dominant for language over the left, and we found that her seizures are coming from the left. And these are pictures of her PET scan and MRI. We did an MEG, magnetoencephalography, and we found that her seizures also come over that area, but we still wanted to do invasive recordings. She ended up having subdural electrodes placed on her brain, so we can do careful language mapping, because we were hoping okay, it's around the area of language, but maybe we'll find that some areas where the seizures are started are near language and not exactly on language. We did a functional MRI also. And unfortunately, what we found is that the area exactly where the seizures start are the areas of language. So obviously, epilepsy surgery was not something that we can do to her. What we did, we decided to implant an RNS device, responsive neurostimulator device, and we put in 2 electrodes around the area where we thought the seizures started. And this is an example of how the device looks. And you can actually see all those squiggly waveforms, and you can see that the patient starts having a seizure and the seizures stop. And this particular patient is currently, she got married, she's productive, and she has a seizure reduction of 99%. And that brings me to what I'm just trying to wrap up this talk to one of the most important things is never lose hope, and there's always hope, and this is still work in progress. But I do think that having 3 approved modalities now for neurostimulation has really changed the landscape of epilepsy for patients with drug-resistant epilepsy. And if any of you have questions, I'll be more than happy to answer any of those questions. Any questions?
Well, hi, Dr. Elisha. Good to see you again. It's very interesting talk, even though it's not exactly my specialty, but I'm very impressed always by your knowledge and experience. You mentioned in one of the slides in the middle that uh, some of the RNS are used also in movement disorder. Are the same?
No, no.
The same or different?
Yeah, well, I'm home, so I apologize. I have my dog barking at me that not the RNS, but the deep brain stimulator. So the deep brain stimulator in the thalamus or basal ganglia, has been used for movement disorder, but it's been approved the last couple of years, last few years, it's been approved for epilepsy, but the target is different, so what we're using, the approved target for deep brain stimulation in epilepsy right now is the anterior nucleus of the thalamus.
But it is the same device or different device?
It's the same device, but now that device now has capability also to monitor local field potentials.
I see.
So the application is slightly different.
Great, thank you.